Hello, everyone. I always want to say good morning, but I know it's so different because we have so many international folks. So wherever you are, good, whatever that is. If it's morning, good morning. Liz, it's like
Good
early.
something.
Yeah, it's early afternoon. I know for East Coasters, it's lunchtime. And then I know that the UK somebody mentioned they're 8 hours ahead of us. So doing math, that's like 5 o'clock in the afternoon. So wherever you're at, we are happy to see you. I always think of you all as family. So Liz and I love coming here each Wednesday and providing you with support and community and resources. Before we jump into everything, obviously, one of the things that I notice with myself and with most people with OCD is when things are going on around us, our brains tend to kind of fixate on them, get very anxious. So I know a lot of people right now are super anxious with all the conflict that's going on over there between Russia and the Ukraine. And so we want to first obviously just validate the extra fear, the extra anxiety, the obsessions and the triggers that you have. And one thing that's nice about doing these live streams is when there's things that's kind of in everybody's psyche and happening in real time, we could address that. So we first obviously hope that anybody that's a member of the OCD community out there is safe and they are taking care of themselves. We are thinking of you. We absolutely, obviously, our hearts go out to everybody that's being impacted. So we just want to say that we hope that you're safe. We hope that you're okay. And, that's why we do these, is to have a community and have support, because a lot of times people feel isolated and alone. We don't want you to feel that way.
100%. And I appreciate you talking about it, Chris. And I think, for us, we want to make sure that I think these talks and these community connections and collaborations are opportunities for us to support one another. And it's certainly a time right now where people may be needing extra support. And we want you to know that we are here for you however we can be, but certainly for those of you who may live in impacted areas. I know we have viewers from across the globe or who have family members or friends who do. Our hearts go out to you, and however we can support, we would love to. But we're grateful you're here, and we're hopeful that you will still find this webinar to be useful or helpful in some way, despite all of the chaos and anxiety and sadness that we're all feeling and experiencing on different levels right now.
Absolutely. Really well said, Liz. So we're all here for you. As Liz said, this is a community. Announce where you're from. We always like to hear where everybody's from. So whatever platform you're watching on, go ahead and go into the chat part, whether it's YouTube, Twitch, Instagram, etc. I mean, not Instagram, Facebook. And just kind of in the comments, let us know where you're from. Where are you watching us from? And you could say your name and say hi. I think what happens a lot that I see is when you announce yourself, people then end up kind of finding other people from a similar area, and you start making bonds, which is so important. And also throughout this, the Ask the Experts is really designed to be able to ask your specific OCD questions. We can't be your OCD clinician, but we can definitely give you direction, answers, resources. So throughout this entire time, please go ahead and put questions on whatever platform you're watching, and then Liz and I would love to answer those. We also got some pre-submitted questions, so we'll go back and forth. Before we jump right in, I want to make a couple announcements. As always, this isn't intended to replace therapy. Although Liz and I are clinicians and see individuals with OCD in our state, this is more to give you support, like I said, and information, but not to replace therapy. So for treatment-related questions, please work with your provider or contact a local clinician. You can always use IOCDF's online resource directory at iocdf.org/find-help, and you can locate a trained clinician near you. This is also not a crisis hotline. If you're in a crisis or are ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the suicide prevention hotline at 800-273-8255. Lastly, this is a safe space. Please be kind and respectful to everyone. You guys are always so good at doing that. This is being broadcast on several social media platforms, is being recorded, so be mindful of that when you make comments. At the end of the day, we're all here to support each other. Whatever platform you're on, make sure you like and subscribe. If you're on YouTube, hit that subscribe button, like us on Facebook, or whatever platform. And don't forget to join us for a very special live stream. It's going to be in 2 days. So this Friday, March 4th, we're going to do part 2 of last week's Lunch and Learn. We'll answer more of your questions and talk about the gold standard of ERP, the new gold standard that Liz and Dr. Grayson talked about. And we're going to have, like I said, guest speaker Jonathan Grayson. So submit your questions ahead of time at iocdf.org/peace of mind. So without further ado, Liz, I was thinking maybe I could jump into one of the questions that was pre-submitted that you could start with.
Please, let's do it.
So this is kind of like a cornerstone of ERP. So somebody submitted questions, said, how does somebody start ERP when making a hierarchy is an exposure? So a lot of times, you're sitting there as a clinician, you're working with someone to make a hierarchy, rank the, sometimes ranking the sud scale, however a clinician does it. What would you advise if somebody's absolutely just struggling with creating the hierarchy? And that's kind of the first step in a lot of people's treatment.
Yeah, no, this is a great question, and it's tough because I'd want to know a little bit more around what level exposure is this, right? So if this is really like an 8 or 9 and a really high level exposure, we may not want to start there. And I would actually encourage you to talk with your provider about, are there ways we could do some exposures prior to starting a hierarchy? So like we can think about exposures that might be on that hierarchy, but go ahead and get those started as the first step, because again, we want to work our way up to higher level exposures. We don't want to start with that. And so this is where it's really important to be candid and honest with your clinicians, right? We don't ever want patients not being willing or feeling uncomfortable to talk to us about how they're feeling, their anxiety, their concerns. Instead, we want this to be an open book. We want it to be open collaboration with one another, because that allows us to meet you where you are and to really be able to provide helpful feedback, support, but also to jump in where we need to jump in at in a way that's going to be useful. If you find that like anything is an exposure, and so doing a hierarchy, it's an exposure, but not doing a hierarchy and just jumping into exposures is the same as an exposure, I would encourage you to think about doing it, right? So again, remember, we shouldn't be starting exposures until you're ready. And sometimes the hierarchy is made during more of that psychoeducation phase versus in the active exposure phase. And so you may want to talk to your clinician about, this is an active exposure. And so I wonder if we can do a little bit more psychoed. But if you're bought in and you're ready to start exposures, what better of an exposure than to start with the hierarchy if you're willing, right? Because you're probably going to need it anyways. Most clinicians, a lot of clinicians use it in treatment, not all do. But again, if you're going to need it, if it's an exposure, treatment's an exposure. So I say lean in if you can, but if it's too high and you know that you won't be able to do it without rituals because it's just too high level of an exposure, talk to your clinician about that.
Well said. I don't have much to add because I think you're right. And sometimes even I've had clients before that the psycho ed can be triggering, just having to like read things and then needing to read it over and over. Or if I read it to them, they have to ask me to keep repeating myself. So sometimes right out the gate is, a trigger, but that's what we do as clinicians. We don't treat everybody as like the same. We really work on how can we get this person to get the information we need, et cetera, without being stuck. I think this would be a good question also. It was live asked by Kelly Wilson at 12:05 a.m. Fran. It says, I could use support for a child in Indiana. I need a therapist for him. I'm on 2 wait lists, but both are for months. So obviously the first thing I would direct you to is iocdf.org/find-help. But Liz, maybe you can talk to, because this is something I think we're all feeling at all areas. So many places are impacted. Why do you think right now more than ever there's waiting lists? And what are some of the things that you give advice to people that they could do if they reach out to your clinic and there's just a waiting list? Or what do you advise for people in this situation? I think a lot of families are going through this right now.
Yeah, no, it's a great question. And I think across the board, I was just doing a talk this morning to a school in town. We're just seeing an increase in individuals accessing mental health treatment, which to me actually excites me because it means that people are seeking services. But of course, there's concern of, are we seeing a big rise in mental health and what's going on right now in the world? And we know that there are a lot of things to be concerned about, but keep looking and keep searching. So it's amazing you're on those 2 lists. What I will say is call those people once a week and just say, hey, has there been any movement? Have there been any cancellations? Because sometimes you might be on a list, but somebody who's kind of that squeaky wheel and just kind of reminds people like, hey, I'm here, we want to get in. You may be able to say, hey, we actually had a cancellation. If you want to take it, we could move you up. The other thing I was just Googling, if y'all saw me distracted for a second, Indiana has introduced SIPAC. So it looks like it was introduced in January of this year. And what SIPAC is SIPAC is a group for clinical psychologists that if they're a member of SIPAC, they can practice in different states. And so the reason that's a really great option for you guys is that It allows any clinical psychologist with OCD background that's a SIPAC member, which a lot of them are, I would say almost majority of OCD specialists are becoming SIPAC members. They can now practice in different states. So they're actually, that might open up some more options and availability for you. So you don't necessarily have to stay limited to Indiana. You could look at who are some psychologists that you've heard from that you really think are great, and could you call their centers and see if any of their clinicians are SIPAC members and could practice in Indiana. So there's a lot of options. There's a lot more resources than previously existed. And what I will say is, while I want that number to get down, the fact that you're on a list, and here's what I want you to hear me saying, it is better to wait a month or two and be able to get to a really good OCD specialist than to compromise the level and type of care to get into someone quickly. And so again, if there's someone else you could get into quickly, whether it's even like pastoral counseling, supportive counseling to do as a bridge so that they have some support and someone to talk to until they get into that talk therapist or into the OCD therapist, great. But what we don't want it to be is that we start doing talk therapy or something else instead of OCD work, because we can get started with them right away. There's amazing apps like NoCD, there's OCDchallenge.org, there's great workbooks and books. You can go to iocdf.org and also click on Find Help. There's lots of resources around books and tools that you could use to start getting started on now, as far as reading, gaining some education, having some good support. These different conference webinars we do, IOCDF's conferences that are hosted, right? There's lots of ways to connect and engage while you're waiting. But I hope and believe it's worth the wait, but also consider other resources besides just licensed providers in Indiana, if that now might be an opportunity for you.
Yeah, the only two things that I'll add is part of our code of ethics here in California is if we put somebody on a waiting list and we know of other, trained clinicians that we absolutely support and recommend and know are good at what they do, we give those as resources. So I know for us at the Gateway Institute, like if we have somebody on a waiting list and we know of somebody around us that doesn't have a waiting list, we will give you that referral. We would never give you a referral that we don't trust, but that's one thing that you could do is if the waiting list, let's say it's not like a couple months, let's say they're, because I remember when I was trying to find help for a client of mine traveling back to New York, some of the waiting lists were a year. So if somebody has that long of a waiting list, just ask them, I'll stay on your waiting list, but is there anybody you recommend in the area? And then the other thing is sometimes treatment centers will have multiple therapists. So their waiting list might be a little bit shorter than somebody who's a private practice just by themselves and might have a longer one. But I'm so glad that you're seeking out hope. And the biggest thing that Liz said that I would shout from the rooftops is don't go somewhere that isn't good, because sometimes what happens is people rush to a place that doesn't have a waiting list because they want to get them in for EMDR or psychotherapy or something else besides, OCD gold standard. And then what happens is that person burns out on therapy, has no faith in it. And then when it does open up to a qualified center, they don't want to go because they're already burnt out.
Totally. Let's hop into that next question for you, Chris. I'm going to throw it your way. This is at 12:08 from Grace. What would your advice be for balancing mental health, advocacy, and OCD? I feel like I'm a hypocrite at times when I advocate about mental health and OCD treatment, because the things I encourage others who are struggling with mental health or OCD to do might not be something that I'm doing myself. I want to help others and encourage those people to embrace the uncertainty, but I also find that I struggle with that myself. And I know Grace put a part 2, which is how would you suggest at 11:13 or 12:13 your time, Fran and Skyla, how would you suggest going about educating those around you about OCD without coming across as rude or angry? I don't know how to respond to the too common "I'm so OCD about" that I hear too frequently, especially from close family and friends who I don't want to ruin a relationship with over my frustration of how they use OCD as an adjective. So first question, which I love, and Grace, we get this all the time, and no better person to answer that than Chris, is like, how do I advocate if I feel like I still have some of my own work to do?
Yeah, I mean, when I was first starting out advocacy, I was fresh out of treatment and I still had compulsions. I remember when, my mom and I flew out to do the Montel Williams show. I was so triggered by every single thing, just getting on the plane, getting into the studio, being on camera with BDD, all those different things. And what I looked at it is people don't only want to hear from individuals who are, in recovery and doing extremely well. We want to hear from all over the spectrum where people are experiencing. So that's the number one question I get from other advocates is they just say, look, like, I feel like I have imposter syndrome or I'm a fraud because I'm still struggling. First of all, it is so good to advocate for yourself, because I know for me, it kept me honest in the beginning. It's like if I was doing a talk that day at the conference and I wanted to do a compulsion back at the hotel room, I'm like, no, I don't want to let myself go and speak and tell other people what they should do to get better and then not do it myself. So for you as a person, it is so helpful in your recovery. And I believe it's one of the reasons that I haven't had an extreme relapse since I finished treatment, is because I'm always advocating, doing exposures with clients constantly in sessions. So I'm pushing myself. But for the community, the community wants to hear from all different people. They want to hear from people that had refused treatment for 20 years and finally said yes to therapy and are in session 1, because there's other families that want to hear, what did it take for you to get into treatment? So people on different levels of on their road to recovery, road to management of symptoms. I think it's important for the community to hear all over. I know there's a lot of times, even with our lead and national advocates and our IOCD advocates, sometimes people are like, hey, I'm in a really low place. And some of, once they kind of get back on their feet, they'll do a live stream or they'll write a blog post or they'll do a talk. And it's some of the most powerful things we hear. So don't be discouraged, Grace. We need people like you in our community for sure.
Absolutely. Question 2 is about how do you not get angry? And I love this question because, I will say, I'm going to give my sister a little bit of kudos, but years ago, we were sitting at the kitchen table and I was like, come up with some phrases that we can put on OCD swag. And one of her top ones was OCD is not an adjective. And it's been so fun to see how much that's used now and dispersed across the community and how many advocates use it and pitch it and promote it. And I love it because it's like, okay, good. This has gotten the word out. But I also hear what you're saying, Grace, which is like, how do we not get angry? Because for a lot of us, when OCD is used as an adjective, it's not just annoying and frustrating, it's hurtful. Because for many of us, like OCD is so far the farthest from the truth of being just an adjective, right? It's a debilitating mental health condition. At the same time, it's really important for us to do 2 things, which is to be able to properly educate when people struggle with OCD or are talking about it and not shut them down. I think one of the things we've really learned a lot lately in our current cultural climate, right, is that canceling someone or doing certain things that's really shameful, like, do they really learn, right? Is it an opportunity when that happens for someone to learn and grow? Because what we don't want to do is get so mad that then we blow up or we say something that like they're not going to be learning or they're not going to be listening to what we're saying. And so, Chris, what are your thoughts? How, when we are frustrated and hurt because it's a big deal, how do we still convey empathy and encourage them or create an opportunity, I should say, that would encourage enlightening and education versus people shutting down?
Yeah, I would say the first thing that I want to kind of just validate what you were saying, Liz, and obviously what Grace said when she asked the question. I think it is hurtful. I mean, that's one of the hard places to put ourselves in. I mean, I don't think any of us want, people to cry for us and feel sorry for us. It's just difficult when you're at some of your lowest moments and people find out what you're struggling with and just really kind of dismissing it or not taking it seriously. And then when you see different people talking about it, there was an episode of The View, I think it was like yesterday, a client showed me, and they were talking about perfectionism. And one of the members on the panel did great. She talked about body dysmorphic disorder. Another panelist talked about anorexia. Another panelist talked about like having OCD and needing to go to therapy and saying, look, like, I know it's never going to go away. I'm going to have to learn to like live with this and be at peace. But then you had the inevitable, oh, I'm looking through this list and I think I have a little OCD too. And it is frustrating because there's such a world of difference. And we don't hear like I have a little bit of cancer, I have a little bit of MS. With that said, I mean, Liz made such a good point. Nobody's ever going to support our cause if we attack them and yell and scream. So I'm the biggest believer in like deep breaths and taking a break. And then when you get to a good point, education. I mean, when I was going through my undergrad and grad school, there were so many misconceptions, even from professors about OCD. And I loved educating them. One of the projects that I had to do something on stigma reduction. And I found a website where you could buy hand sanitizer. This was pre-pandemic, and I put a sticker on it that says, just because you use me, you don't have OCD, find out more, and then had the IOCDF's website. So I think education is going to be the most important part. And then with your community and your friends and those who have OCD, you can kind of complain and get frustrated. But I have been so like pleasantly surprised at how many people, when I educate them, they're fascinated. They're like, look, I never knew this is debilitating. Yeah. And I think that that's going to be the way that we reduce stigma and rise up to education.
I love what Felice said too. She said, when people tell me they have OCD or a little OCD, I apologize that they suffer from a horrible, debilitating disease. And I ask if they have a therapist that provides ERP, and it really shifts the conversation, because it's like, it's so perfect to be like, wow, like, I'm so sorry to hear about the struggle. And because now we're not minimizing it, right? We're not meeting them where they are of like, oh yeah, OCD's funny. Oh yeah, it's not a big deal. We're actually talking about it from the perspective that we know actually truly exists for OCD, which is how tough it is. The other thing I'll say is think a little bit of the way IOCDF works, right? So many of you were a part of our community and collaborating with us when we had an individual on social media who has a lot of followers. This was about a year ago, where he was talking about celery juice being the cure to OCD. And the back channels, so those of us that advocates, we were pissed, right? I know I don't cuss a lot, but like, we're angry, right? It was really frustrating for many reasons. Number one, think about all the people who buy into that because they just want to get better, right? Who don't know different, and that you're missing an opportunity to get them to good treatment. But number two, like, it's bogus, and it really deminimizes our illness when you're saying like it can be cured with celery juice, compared to understanding that it is a medical condition that requires specific medical and treatment interventions, behavioral interventions, and medication. And so anyways, back channel, right? Chris, I remember Chris, myself, Jeff Shemansky, Ethan, like lots of others, we all got on this phone call with IOCDF and we're brainstorming. And what did we come to as a decision? We didn't come to the fact that like, let's bash him and let's repost and talk really negatively about it and engage in shame. Instead, we decided to make this really cool educational slide that talked about what is OCD and what is the proper treatment, right? To educate on what it is and what makes sense. And we did repost that to him and put, I think, a text where we encouraged him to understand appropriate treatment. But what we learned is that talking negative about him, that would get us all mad and fired up. But would it actually give people good resources, which is our end goal? Or would it get us all just frustrated and more upset that people don't understand it, right? And so there's ways that when we're frustrated, can we still channel education? And I think you hear that across the board from Chris, from Felice, but from others, is that education tends to be the way that people can learn at their own rate, and then ask questions. And then when they become more interested, it's an opportunity for us to even educate on a deeper level.
Well said. Well said.
All right. So I love the feedback. So Bettina at 12:21 p.m. Guys, how would you describe recovery? Will I have the same intrusive thoughts, but learn to live with them? Great question. Chris, I'm gonna let you take it.
Yeah, I always, what I like to do as a therapist is like day one, explain to them the goal of treatment, because I do believe that a lot of people come in thinking that the goal of treatment is to get to a point where you never have thoughts and you never have feelings, you never have anxiety, etc. Everybody on the planet has anxiety. So the goal is to never get to a point of having zero anxiety. That doesn't even exist in anybody without a disorder, right? So the goal, what I tell people is like, you're going to have intrusive thoughts, you're going to have intrusive feelings, and you're going to have that periodically throughout your life. The difference is we are going to learn how to respond to them, because that's really where your power comes from. And one thing that Liz has always screamed from the mountaintops, and I'm on board and I love it, is it's not going to be a struggle. It's not going to be suffering. You don't have this chronic disorder until the day you die. You're going to be an ERP and you're going to struggle and you're going to this and that. I always tell people like where I'm at in my life, like I'm more annoyed by taxes and traffic and air pollution than I am OCD. I mean, you get to a point where OCD is really in management. And if you do have a thought or a feeling, you're able to quickly acknowledge it, dismiss it, move on. I mean, it really gets to a point where it almost doesn't impact you. And so the goal is not to try to strive for zero, because then I actually see people turns into a new obsession. They get to a point where they're like, I just had an intrusive thought. What do I do? What do I do? And I'm like, but you know what to do. You've done so great in therapy. Why is this different? And they're like, because I'm supposed to have no thoughts when I'm recovered. And I'm like, no. There's so many studies. There was a really good 2015 study with college students. Individuals without OCD also have intrusive thoughts. So you can't even get to the point of not having them. The difference is they don't obviously ruminate on them, do mental and physical compulsions. So what I really want to make sure clear, and then I'm going to hand it over to Liz, is I don't want people to hear, because I didn't hear that when I entered the community, thank goodness. And that's why I had such hope for my own recovery. I don't want people to think that where you're at right now, while you're struggling, it's going to be like that for the rest of your life. And you're just going to be better at handling it. As you get better, certain things that used to trigger you and bother you aren't anymore. And the things that do are going to be much more quiet. and you'll have the tools to handle it. So you'll get to a point where you're absolutely living a fulfilled life.
100%. And here's what I'll say. We can't get rid of the thoughts, but what we can do is change and shift the power that the thoughts have, right? So while you may still have intrusive thoughts, they will be just thoughts. They actually won't be intrusive. They won't be scary. And so you actually won't have intrusive thoughts. You'll have thoughts, which is what other people without OCD have, right? We can't get rid of thoughts, just like we can't get rid of anxiety, but we can certainly make anxiety not feel dangerous, make anxiety not be something we're afraid of. And that's the big difference, right? Is can the thoughts just be a thought that comes and goes, we pay no attention to, and that we forget what we had, versus it being intrusive, scary, debilitating, and coupled and, accompanied with anxiety and distress.
Yeah, absolutely. And what I always tell people is like, you'll get to a point where when you start to talk about OCD, you almost start to talk about stuff more in the past, because what you're dealing with on a daily basis looks nothing like it did prior to treatment.
100%. Last questions. Go ahead, Chris.
I was going to throw out a question because I think it's good because there's such high comorbidity, but Uvis Hant at 12:17 a.m. says OCD and ADHD, anything for me. So do you see a lot of individuals with OCD also have ADHD? And what are some of maybe like the unique challenges people deal with both? And what are some of the things that you see people trying to manage with both?
100%. I'll be candid. This isn't my like true specialty is the comorbid ADD and OCD, or ADHD and OCD diagnosis. It definitely exists. What I will also say is that we do sometimes find people might be misdiagnosed with ADD, ADHD early on, and it ends up being OCD later. And so we really want it to be, we would encourage people to have a true neuropsych assessment where they've done a true battery and can really have an appropriate diagnosis of ADD, ADHD, versus maybe like your pediatrician early on was like, oh, it sounds like ADD, and prescribed medication. Because what we want to know in general across the board for any diagnosis is we want to treat the right diagnosis, right? So if it is OCD and ADHD, we want to know how they impact one another, what medication you might be on for one versus the other, and the impact it might have on the different illnesses, and how we would treat them differently, right? Or the way we might better understand your OCD if you live with ADHD compared to if maybe you live with ASD compared to if you live with an eating disorder, right? And so we really want to understand the full picture of everything that's going on and treat things both together, but also separately, right? We're not going to treat OCD and ADHD the same way, but we definitely need to know if you have a comorbid diagnosis, because it might impact the way we treat each one of those versus if you only had one of those diagnoses individually, if that makes sense. Chris, anything for you to add?
Yeah, I work really closely with an ADHD organization out here that's pretty close to our office. And, there is a high comorbidity. But I mean, I was going to say the first and foremost thing is what Liz said is so accurate. You have to make sure you get a proper diagnosis, because a lot of times I'll get clients that were diagnosed with ADHD. And then when I talk to them more about it, it's really because they're having intrusive thoughts in class and can't focus. So the one difficulty that individuals are always going to have is OCD tends to have us be very cautious, think things through, hesitant, whereas ADHD has people take a lot of kind of like bold steps. A lot of times things are just the word's not coming to me. It starts with the letter I, but they're much more impulsive. Thank you. Impulsive than OCD. And so sometimes what people will report to me is that they struggle because sometimes they're impulsive and sometimes it's almost like a tug of war in their head. So definitely want to get help for OCD. The reason I work with this other ADHD organization is find somebody that either can treat both. Some people may be able to do that, or find a therapist that treats OCD who can refer you to somebody who really works with ADHD, because there are some behavioral plans that you can do, certain kind of like behavioral changes you can make. So a lot of times older adults with OCD and ADHD are forgetful and lose things and miss doctor's appointments. And so there's certain strategies you can do. The last thing that I'd recommend is if you're going to work with a psychiatrist, make sure they understand both, because there is sometimes where an ADHD medicine can make people feel more anxious. So make sure you find someone that can balance both.
100%. All right, so let's keep going. We've got lots of new questions, which is great. Thank y'all for your feedback about our response to the celery man. I love calling him now. So Fishman at 1226 had OCD since early childhood. Most lasting problem is religious doubt, anxiety, in spite of remaining active in my faith. Any suggestions? So I will just start with this and just say the real suggestion is please remain active in your faith, right? Because we want us to continue to do the things that that are valuable and important to us, even if it may be triggering. We certainly don't want you to avoid that. But if you are finding OCD and anxiety are still impacting your faith relationship, I want you to address that with your clinician. I want you to do some specific scrupulosity work, and I want you to really lean into that, because my goal for you, and I know all of our goal at the foundation, is that you can have a healthy faith relationship that isn't controlled and isn't impacted by OCD and anxiety. What we know is that if OCD is impacting your faith, ERP can help. And leaning into uncertainty can help. And it is really where you will get that freedom. We talked a lot about that with Dr. Grayson last Wednesday, and we'll be talking again with him on Friday. So definitely make sure, for those of you that have like, how do we do ERP for this type of OCD? What does this look like? Please join Friday, because we'll be getting further into the weeds on this discussion. But it's really about leaning into the concept of treatment across the board so that you can get the freedom you deserve, because you can get it even for any different subtype. Next question. Oh, go
Wait,
ahead.
real quick. This would be a great time to plug. Yesterday, the registration opened for the IOCDF
yes.
Faith and OCD Conference. It's happening on May 9th. So the conference is for faith members, faith leaders, and mental health professionals. You can get more info and register at iocdf.org/faith conference. So anybody that's dealing with scrupulosity or faith-based OCD, that would be a great place to go.
100%. Next question is, how do you handle feelings associated with the thought? So it's a great question, Tracy. And what I want you to know is that the feelings, so the anxiety, the distress that comes with these thoughts, will start to change. It will start to lessen if we start to respond to the thoughts differently. So the more we respond to our thoughts as we respond to fear, right? We're scared of them. We try to fix them. We try to solve them. We engage with them. The more the distress, the discomfort is going to come with every thought, because what happens is we are telling ourselves we should be afraid, we should do something, we should fix it. But the more we quit engaging with our thoughts and we quit responding to it, and we don't treat it as fear, right? We kind of like, oh yeah, thanks for that anxiety. I'm not going to address you today, right? Like, you don't deserve my time or energy. The feelings associated with the thoughts will start to lessen. And so as you do active ERP and OCD work, you should see that the thoughts should come with less frequency, but they absolutely should also come with less intensity. The feelings associated with the thoughts should start to decrease. And that is a pretty awesome and rewarding feeling when that starts to happen.
And I'm glad that you mentioned that, Tracy. I think a lot of times people talk heavily about thoughts, intrusive thoughts. But what makes this disorder so insidious and difficult to handle is the associated feelings. And so a lot of times, the feelings are so loud, and that's why we treat the thoughts as important, because we're so used to in life that if we're having a high emotional reaction to something, that it's important and prioritize it. So one thing that I learned in my own care is just reminding myself that just because the feelings are loud does not mean the problem is loud. It just means that OCD is being loud. So the good thing is, like Liz said, is as you deal with the intrusive thoughts, those feelings go down. And then sometimes I would get to a point where a thought would come up, but there's no feeling associated. And I almost pictured OCD as being like weaker and taking like one last like ditch effort to be like, are you sure you don't have cancer? And it's like, no, I'm good. Bye. So it's like, that's such a great part of the treatment that you get as the payoff.
Totally. So the next question is, at 11:28 from Tracy, I find change of any kind always triggering my OCD. Is this common? And I'll answer, and Chris, I'll throw it to you after that. Is absolutely, it's common, right? When you think about life in general, any life stressors, any big shifts, changes, things that happen, right? It increases our vulnerabilities. It increases our anxiety. It increases our distress level, right? So even think about right now with all the conflict going on in the Ukraine, right? For a lot of us, we may already be feeling anxious and upset and stressed. And so our ability to tolerate more anxiety, stress, or distress rate is less than it was if we weren't feeling that level of anxiety or distress that we're feeling right now from external things that are also going on we don't have control over. And so it's absolutely common. But what I will say is keep pushing through, right? So even when you feel that extra layer of distress, even more the reason to do ERP and not engage. Because remember, engaging with our OCD, there's times it makes it feel better, but often we get more stuck and we end up feeling worse. The more we try to answer these unsolvable questions, the more we try to get certainty, because that's what OCD tells us we need. And so lean in even when we're feeling stressed if you can, but give yourself grace. So also take care of yourself and do lots of self-care.
And remember, OCD is all about control. And so when things are going on in our lives, and it can even be good change, it could be a move that you've wanted to take, an engagement, a child, I mean, there can be all these great changes in your life. The OCD jumps in. OCD wants your life to look like Groundhog's Day. It wants it to be predictable and the same. And so when changes happen in your life, the OCD is like, we can't handle this. There's too many unknowns. There's too much uncertainty. Hey, I have an idea. Let's do a bunch of compulsions. Those are safe. Those are familiar. You know what's going to happen when you do those, and you can be more certain and safe. And so don't be fooled. I tell people, if you know a change is going to happen, you can't always predict it. Be prepared. Even like sickness, sometimes when people get the cold. So just be prepared that OCD is going to try to make itself relevant, and you don't let it come back stronger just because you're having change.
100%. Chris, next question for you, and it's a great question, is what would you suggest? It's from Costas at 1228. Sorry, I always try to calculate the times for y'all on the back end. What would you suggest about compulsive mental counting?
Yeah, so mental counting could be done for a lot of different reasons. Sometimes it's perfectionism, sometimes it's a just right feeling, sometimes it's counting to a certain number because of magical thinking. If I can count to 7 before that white car passes me, my mom's going to be safe. Other times it's people will just count as sort of like an anxiety relieving behavior. Like they'll just count in their head to certain numbers. There's all different reasons that we do it. So what we always want to first recognize is that it's a compulsion. I think a lot of times if people do it, not even sometimes clients will say, hey, look, I do this without even like planning it. I think it's an obsession. It's like, no, it's a compulsion. It's something that even though we don't want to, we're choosing to engage in. And so like any compulsion, our goal is to eliminate, but if we can't eliminate, to reduce. So some of the things that help clients with counting is if they have certain numbers that they have to count to that are right. So let's say they have a pattern. Clients will have like 2, 4, 6, 8, 10, and they have to count to that like that. It would be purposely counting bad, could be an exposure. So, if a client doesn't like odd numbers, it would be counting 1, 3, 5, 7, etc. Sometimes what's better than that is clients will just count, OCD wants a perfect counting sequence. They'll kind of count erratically. So they'll be like 2000, 98.7, 403-2. And sometimes that kind of mix it up. The best thing to remember is OCD loves patterns. It loves for things to be a certain way. And so we kind of want to break down the system. So with the mental counting, you want to kind of break down the system that OCD's created. And what I'd say lastly is usually the mental counting is connected to a certain trigger or obsession. And so sometimes the counting may just be kind of like the surface level compulsion. Make sure that you're tackling whatever is bringing on the counting. So let's say, like magical thinking. Let's say you have to count in order to have a family member be safe. Instead of working so much on the counting, you can do the things I said. Also make sure that you're doing exposures towards the uncertainty that you have about the family member being safe or not, and really pushing back against it. And then the eliminating the mental counting would be the RP and ERP, making sure that you don't do that to feel better.
100%. So remember, we treat mental counting, as Chris said, as the compulsion, right? That is a compulsion that you're doing due to an obsession or a thought. And we want to treat it the same way as other things. We want to reduce that compulsion, right? So eliminate the ritual. So no longer engage in mental counting and start to do some what we call uncertainty work. So this might be things like Chris mentioned of doing it wrong, counting wrong, or it might be things like, leaning into that fear. So why are you counting, right? Are you counting because you feel like counting keeps you safe? Counting serves some sort of purpose? Like what is the greater fear? That's important too. So remember, when we do exposures, we want to do the exposure. So we lean into the trigger or the fear, the response prevention, we don't count, we don't engage in the behavior, and we lean into the uncertainty, right? So if the fear is something bad might happen if I don't count, I want you to not just not count, but also lean into like, yeah, and something bad may or may not happen today, and I'm still going to go live my life despite the fact that I didn't count just now, right? That's what's the really important piece. And I want to just jump to a question 2 down, which is how do you touch doorknobs and handles and other public surfaces if you're dealing with contamination OCD? And it's the same thing, right? We want to slowly and systematically work up to that exposure. So the exposure is to touch the doorknob, to touch the contaminated surface, to touch that thing that feels dirty, that feels scary. The response prevention is to not engage in the response, to not hand wash, to not clean, to not do any of those cleaning type of behaviors. And then the uncertainty, which we're going to talk more about again on Friday for our OCD gold kind of treatment part 2, is to lean into the fear. Is the fear for you, right? I'm not sure, Midhan, if the fear is something like I'm going to get sick, I might get someone else sick, I'm going to get a disease, right? Because the fear can be different. but it's to lean into the fear, lean into the fact that like, yeah, and I may or may not get sick and something might happen and I'm still going to choose to go do these important things to me despite the fact that I'm feeling dirty or I'm feeling like I could be contaminated, right? So we want to lean into that fear as well, but we want to do it slowly, systematically. We're not going to have you start with the hardest doorknob at the most contaminated place. We want to start with doorknobs that feel safe because, again, so much more important for you guys to do small exposures with big or full response prevention. So all the way we do a small exposure and we fully lean into not engaging in rituals, than to do a big exposure but end up doing some rituals.
Absolutely. The last thing I'll add to that too is what great part of doing this treatment is to then reflect with your therapist what has been able to open doorknobs opened up for you. You know, how freeing is that? How does it feel to not have to like stand there and act like you're on your phone until somebody opens the door so you could squeeze in? So reflecting on the benefits of the exposures can motivate you to keep going.
I love this. And I want to spend a second because I actually talked about this in group here on Monday. It is so important after we do exposures to recognize what we did and what that means to us in our life, right? What values is that going to allow us to live by or lean more into? What opportunities does that now open that previously might be closed if we instead engage in those rituals? And so I love that, Chris, because it is so important for us to be proud of these exposures. Sometimes I find us like not feeling pride because we're like, oh, well, anyone should be able to open a doorknob. Like that shouldn't be a big deal. It's a big deal to us. It's a huge accomplishment if it's something you've been avoiding and something you're triggered by. And so be proud of the work because you deserve that. Next question. And Chris, we're going to start doing more of our rapid fire because we're getting a lot of them, which is what always happens. But the next question is from Gentile or Gentle, sorry if I'm saying that wrong, at 11:30. I haven't been to an OCD specialist before. Is it recommended to start ERP alone if you know how it works, or should I start with a specialist first?
Yeah, what I would say is if you can start with a specialist, I always suggest that. Somebody who works and really understands OCD is going to be effective in helping you troubleshoot and navigate you through. If you already do know ERP, you don't let alone maybe have to do as frequent sessions then. Maybe you start consistently once a week and space it out. But I would suggest it. If for some reason, whether it's finances, insurance, distance, et cetera, that you can't see a specialist, then like Liz was saying earlier, I would recommend somebody like Jonathan Grayson's book or like the OCD workbook or a workbook that guides you through ERP. And then maybe you can do really infrequent sessions to check in. But I always am going to lean on working with an OCD specialist because that's what I always see works for people.
100%. And the reality is that oftentimes, even if we understand how ERP works and we think it makes sense, there's needs to be some specific modifications for our struggles. And in addition, sometimes like we may be doing something, but we don't realize. So here's a good example. Sometimes people don't fully understand rumination or mental rituals as a compulsion. And they might find themselves like, oh, I'm doing ERP, but you're actually ritualizing, doing mental rituals, but you don't recognize that, where your therapist might be able to help you recognize that. And what we know is if it's not recognized, you're not going to see ERP working because you're still engaging in a compulsion. So in addition, those of us that are licensed clinicians, so an OCD specialist should be a licensed clinician who has background training, education on doing OCD work, right? We're also assessing for a lot of other things. And so it's really important when you're doing this hard, distressing work that you have the support of a clinician who knows how to assess for shifts in your mood, other increases in anxiety or other mental health things that might be going on. And so I think it's really critical. And if it's a possibility, please consider it. All right. So I know, Phil, you asked some questions, so I'll just answer them the best that I can. There's absolutely always additional treatment options if ERP and medication isn't working or you haven't found it to be super beneficial, right? And I think that I cannot sit here and say, here's what you should do instead, because I don't know why it hasn't been beneficial. But what I'll say is some people who struggle with, say, emotion regulation and engagement in ERP might really benefit from DBT, dialectical behavioral therapy, first. For some folks, they've tried ERP and OCD and they need to have, they've tried ERP and traditional OCD meds, but they may need to try some different medication to see if that works. And so there is always ways to modify treatment. There's always other approaches. ERP and medication, traditional medications might be the most effective in the sense that it's kind of the most general effective treatment, but it is not our only treatment. And for many folks, right, Ethan Smith talks a lot about this in his talks. A lot of people do have to do different things to get treatment to work or to then get them ready to engage in ERP. So next question, Chris, for you at 11:33 is, if everyone has these thoughts, then how much distress do I need to have before I should bring it to a professional? Mine are very distressing, but not very frequent. Is it still worth bringing it up?
Absolutely. What I always think of is the letter D in OCD stands for disorder. And what disorder means is it's causing conflict and distress in your life, specifically around social interactions, work, school, general functioning. So even if everyone has thoughts, because they do, the difference is they don't feel distress with them and they're able to dismiss them outright. So based on your answer, that they're very distressing, they may not be very frequent. Once again, OCD, that's why we have the Y box where we test out somebody's severity. Some individuals can have intrusive, distressing thoughts hour upon hour. Others may have them infrequently. So you may have a more mild version or something like that. So I would say definitely bringing it up because they are distressing. Even though everybody has these thoughts, they're not associated with negative feelings, fears, distress, shame, guilt, all these other experiences individuals with OCD has.
And I'm also going to say, if you're on this talk listening, it's probably worth bringing it up, right? Because you're taking the time to learn more and get educated about it, which is indicative that it interferes with your life in some way. It doesn't have to be frequent all the time, but any interference, we want to get rid of that because we don't want it to interfere at all. Next question at 11:35. I'm from Israel. What are you saying? I'm guessing. What are you saying to do if I feel that I can't do exposures?
What I always suggest, and there was another question, somebody asking, like, how do you handle the anxiety in the moment of an exposure? So the answer I would say for both of these is that if you're at a point where the anxiety is too hard to handle or you feel like you can't do it, break it down. I think sometimes people, believe that treatment has to be quick because they hear that, 12 to 16 sessions, you should be seeing a difference. Sure, but if it's not a race. So for instance, with a door handle example, if opening a door handle outright is just too difficult, maybe you have somebody else who, like a friend or family member open the door handle, but you have your hand on top of it and you do that for a week. And then you move to where, both of you are opening the door together. I mean, there's ways to systematically break it down so that you're never so overwhelmed by anxiety that you can't function. The other thing is, don't forget about worry scripts, narratives, imaginal exposure. So sometimes if I have a client that wants to face something, but it's just too difficult, we write a worry script where we take it first person, present tense, OCD's worst case scenario, and have them read and listen to it over and over. And sometimes by addressing it that way through an imaginal, they find themselves feeling a little bit more courageous to then challenge it, maybe still on a small breakdown scale, but challenge it physically.
100%. Next question is, I feel like I have to trust my therapist, blindly trust my therapist, to be able to give up on OCD and do the therapy, but it's like putting a loved one's life in a stranger's hands. Is this common?
Yeah, I mean, I think it helps. I don't know if you feel this way, Liz. I think it helps that I have OCD and I've been through really, really severe, because people do seem to trust me a little bit more because they know I've gone through it. So it's coming from both all my years of training and exams and all the stuff that we have to do. Plus it comes from lived experience, but I get it, Bettina. I mean, sometimes, when I was in treatment, I'd look at my therapist and be like, she better do this first because this sounds like it's going to take everybody out. So what I would say to you, Bettina, is if you do trust your therapist, if this is somebody that really understands OCD, has a good reputation, is doing everything right, you come to the conferences and live streams and everything we talk about is what they're doing, then what you want to recognize is that the goal of treatment, somebody said it on a live stream with Liz and I, it's not fear factor. It's not to put your family in harm, etc. It's really to show you that you can be braver than you think. You can push through anxiety and you can live with uncertainty. So I know it's hard. OCD wants us to trust nobody except it. But if you really trust your therapist, go for it. And just like I said in the last answer, if you're finding yourself really struggling to give up on OCD, break it down smaller, Make sure you're obviously doing exposures, but if the exposures are too big for you to really lean in, break it down even further. But you do want to get to a point where your therapeutic relationship with your therapist is pretty strong and you feel trust in doing the exposures.
Totally. But being treatment being scary is normal. And I want to emphasize that, right? That the work that we do should be scary. It should be challenging, right? We should be pushing you. You shouldn't, OCD therapy is not a therapy that you go to and you just have fun with your therapist all the time. Now, sometimes treatment can become fun, right? Because it's a challenge and you get there, but it should be tough, right? It should be hard. It's not just we're chatting and making you feel good, right? This is not talk therapy. Any advice for coping with the anxiety felt after an ERP session? I find that I'm able to resist compulsions during the session because my therapist is watching, but I really struggle after. This is a great question, Grace, and one that I really want to push, and I want everyone to be thinking about, because this is actually the goal of treatment. And what I mean by that is that after an exposure, if we go ritualize, we shouldn't be doing that exposure. And this is where it's really important to have that strong relationship with your therapist, that if Chris was mine, to say, Chris, I know you want me to do this today, but I want to be candid. Like, I'm not sure I'm ready, because I'm not sure I can maintain not engaging in rituals after. If, however, what you're saying is like, no, I can maintain it, but it's really hard, I again want to normalize that, right? That like sometimes it is much easier when I'm in the office with my therapist to have that support and to not engage in the ritual. But then when I have to do it on my own, it gets a little bit harder, right? When I first leave. This is where we have to make active choices of commitment, right? Y'all hear us say embrace uncertainty, and people are like, there's nothing fun and fluffy. Why do we use the word embrace, right? Because it's not like, but it's really like, are you committing to the exposure all the way? Because if you commit to it all the way, even though your anxiety might spike a little when you first leave, because in that moment when you're by yourself and not your therapist, you have a choice, right? You could go ritualize. If you're committing that I'm not ritualizing, I am doing this work all the way, you will see the anxiety reduce pretty quickly, because you don't feel like you have an option, right? We're not really leaving a ritual as an option on the table that's available to go engage in.
Yeah, I think you answered it perfectly. Absolutely.
We've answered some of the other ones. So Shant at 1143, what do you recommend for somebody who has harm OCD? I feel so debilitated due to the fact that I get a flare up of being triggered by.
Yeah, I mean, what's difficult with this one, I just don't know what time of harm OCD you have, but I'm glad you bring it up, because I think the more we can talk about harm OCD, sexual intrusive thoughts, sexual orientation, et cetera, all these kind of like more intrusive based OCDs and things that don't get talked about as much. Basically what OCD is trying to convince you is that you're a harmful person, and at any moment you can just snap and you can lose it, and you're going to harm people around you that you care about. And so inevitably what someone then does is they turn around and they isolate, they avoid people, they do all these different compulsions to feel safe. But the problem is, what you're probably noticing, Shant, is that's not the kind of life you want to live. You don't want to spend the rest of your life basically locked up in a prison in your house to prevent you from snapping and harming people. So just like we've been talking with ERP, the goal that I start with is, let's look at all the compulsions that you're doing every day on a daily basis. Okay, well, you're not going to the store because you're afraid you're going to harm someone, so you order food to be delivered. Let's go to the store, and if you're not ready to walk in, let's just sit in the parking lot. Let's sit in the parking lot for about 30 to 45 minutes. Let's not do any mental or physical avoidances. Let's just sit there. And what did you learn from that? Oh, you learned that you could go to the parking lot and not get out and harm people. Great. Are you ready to maybe stand out in the front? Walk in and walk through the store and leave. Stay in the store for 15 minutes. Stay in the store for a half an hour. Go to the section that has knives and walking in that area. So the goal is to get to a point to start to face these fears. And what people inevitably learn, because remember, treatment, we learn something from it, is that all of the threats that OCD makes about you being this scary, harmful person and just snapping don't have much evidence to back it up. It's a lot easier then to lean into uncertainty and to start to get your life back. But definitely face it with ERP.
Absolutely. Couldn't agree more. So let's hop into this last question. Well, I had a last question in front of me, and now it looks, oh, there we go. Sorry. At 1144, say, please tell us about treatment for pedophilia or sexual intrusive thought OCD. So I'll start, and then Chris will throw it to you. We've actually, I believe, done a webinar on this. So I definitely recommend checking out iocdf.org/YouTube, or whatever it is, YouTube/iocdf. I don't know. Sorry, Fran or Skyla, you'll have to throw it up there. But go to our YouTube channel. Just go to youtube.com and put in iocdf, and you can find a webinar on this. But here's the thing I want to reiterate. Uncertainty model ERP works for any subtype of OCD, whether you have pedophilia OCD, scrupulosity OCD, harm OCD, it doesn't matter, right? ERP and uncertainty works. And so definitely attend this Friday. It is going to be so exciting as we continue with Dr. John Grayson. For those of you who attended part 1, I know you loved it, and I think you'll be there. For those who didn't, go watch part 1 on YouTube and come on Friday, because this Friday at noon Eastern, we are going to jump into ERP, and we will get much more into the specifics of how to do ERP with uncertainty. And we're going to talk about and give specific examples for all sorts of different subtypes. And so I will make sure we talk about this subtype. But what I will say is the treatment for pedophilia OCD or pedophile OCD is for us to really lean in. We want us to lean into the fears while doing things that we otherwise might not, that OCD has stopped us to do, but by doing things that other people would do. So an example, for many of you, you know, I have a 10-month-old who I love and is fun. She's wild and crazy, but I do have sexual intrusive thoughts, you know, and I had a sexual intrusive thought about her. This was a couple weeks ago. I woke up in the morning and I had a sexual intrusive thought. And in that moment, I have 2 opportunities when I'm first faced with this thought. The first is for me to go towards OCD land, which is to try to solve it, understand it, and try to figure out, why did I have that thought? What does that mean? To make sure it doesn't mean anything and that there's no reality to it and that I don't want something bad. But I can promise you, if I choose that path, I'm stuck all day. I am stuck all day, and I'm more anxious about whether or not I'm a pedophile, I'm a bad person, what that says about me, what that means about me. What I did instead is I saw the thought, I thought about the thought, right? I acknowledged it was there. It was like, okay. And I leaned into like, yeah, who knows what this thought means? And I got up that morning, I got dressed. I actually had to come, it was a Saturday, but then I was running group. So I was coming to the clinic, I ran group. And I remember I was talking about it later in group, telling the patients how, yeah, I had this thought this morning. And I hadn't thought about the thought again until I started talking about it, which is evidence that by not feeding it, by not responding to it and still choosing to live my life, that was my exposure. And the uncertainty for me was leaning into the fact that like, yeah, who knows what this thought means? And I'm still moving on, right? I am still going to live by my values, which also meant I still went home and played with Olivia and spent the day with her and bathed her that night and changed her diaper when I needed to and did these things that otherwise would be triggering. Things like compulsions for pedophile OCD tend to be rumination, right? A lot of trying to solve, figure it out, understand it. So it's a lot of mental rituals, which feed OCD the same way a hand wash feeds contamination. The second, what else feeds OCD besides compulsions is avoidance, right? If I start avoiding giving her a bath or changing her diaper or, you know, all putting diaper cream on and all those things that would be triggering for this type of OCD, I'm giving power to that thought. And so what we want to do is we want to respond the way people without OCD would respond, which is keep living life, which decreases that power that thought has because we're not responding to it, right? We're not responding as if we're scared of that thought. Instead, we're responding as if it was just a random thought. And so we want to do ERP for it. Come Friday, we will talk more. Chris, final and closing thoughts.
Yeah, just about that real quick. I think the biggest concern, people think we're going to have them do something that's absolutely scary. What I always tell people is we only have you do exposures that we'd be willing to do regardless of subtype. To take us out, my final thought, definitely just to reiterate what you said, please come this Friday. Jonathan Grayson is amazing. I know everybody loved him, our first part. So the second part, we're going to answer the questions that people submitted at the first part. We're going to answer more questions. So don't forget to be here right the same place you're watching now this Friday. I think that is the 4th at 9 a.m. Pacific Standard Time, noon Eastern. To take us out, I just want to give a quick answer to Anjali. Says to her 13-year-old daughter, do people with OCD succeed in life? That's why Liz and I do this. You do succeed in life. We are both absolutely living proof. And that's why we do this. We want you to have hope for your 13-year-old daughter that she can live the most fulfilled life that she ever wanted. She's just got to put in the work and do the treatment.
100%. She's lucky to have you because you are her advocate. You're here, you're learning. And remember, Chris and I's story is not the exception. It should be the norm. With appropriate treatment, people can live full, successful lives despite this diagnosis. And Valerie, we love you. Thanks to everyone. And a big thank you to Fran and Skyla in the background. So for those of you who don't know, Skyla is new with the International OCD Foundation. You will get to see her and interact with her throughout upcoming weeks and months and years. But she is incredible. She helps us with these live streams, as does Fran. Chelsea, Heather, so many others. But remember, they wouldn't be possible without the foundation and certainly without y'all's attendance. So thank you, everyone, and we will see you in 2 days.
Yeah, see you Friday. Thanks, everybody. Oh, it's just my face. All right, take care. Everyone, have a great rest of your day. Thank you for joining us, and make sure to go to iocf.org/live or iocf.org for all your information on OCD.